So what do I mean about buccal concavity defects? I'm talking about this aesthetic deficiency that is caused by tooth extraction. This is something that we try to minimize with ridge preservation, but we can't completely eliminate. This creates an aesthetic problem for the implants that we're placing. I'm not talking about the buccal concavity defects that prevent the placement of a dental implant. I'm talking about that buccal concavity defect that creates this aesthetic challenge for us to deliver a high quality aesthetic case for our patients. So what can we do? What have we done to manage this type of buccal concavity defect? We have addressed this basically two ways. We have done an additional bone graft, either at the time of implant placement or at second stage surgery, to create this ideal contour. We've called this a contour graft. And we have also tried to create additional soft tissue thickness to mask that buccal concavity defect and create a more aesthetic implant case. What we have also tried to do over the years is to look at alternative materials to correct this type of problem. So we have used a cellular matrix, for example, but we have also tried to look at some collagen constructs for that purpose. Collagen constructs have a great advantage over autogenous tissue or additional grafting because collagen structures, they are composed of collagen, which is a natural component of both hard and soft tissues in the oral cavity. But these collagen structures that we have used in the past, they have failed to provide long-term results. It's something that, based on the nature of the collagen that was used for this purpose, it's something that created a significant volume for the first couple months, but this tended to go back to original volume over time. So not a very predictable treatment long-term. So what options do we have to treat this type of buccal deficiency or buccal concavity type of defects? Well, in recent years, we have also seen the fast development of absorbable scaffolds for bone regeneration. So these absorbable scaffolds are very different than the bone grafts that we have used in the past. They're nothing more than a collagen matrix that is specifically designed for the formation or the regeneration of alveolar bone. And this is something that has totally changed the way I look at site preservation or implant site preservation or the management of extraction sites. So instead of using a conventional particulate material in extraction sites and having to worry about the turnover rate of this graft material particles, which could potentially affect bone quality in the area, I've been using this type of collagen construct for this purpose. And the great advantage of this type of collagen structure is that since it's a fully resorbable scaffold, this scaffold will resorb and will be replaced by new bone, leading to higher tissue quality in the area. So if you compare like from before and after, and this is a 4-month re-entry on that site, you can appreciate that ridge dimensions have been properly maintained, but we have a very acceptable result now, or a very ideal site for implant placement. So very interesting technology for bone formation. This same technology has been used now for the development of another scaffold to help with soft tissue development. So is this a soft tissue scaffold, or is this an absorbable soft tissue scaffold? What is this? This is a multi-layer membrane-like material that can be either used as a single layer or can be used as a double layer. So I've decided to use this as a double layer based on what I have learned from this, the same material in that sponge form for bone formation. Well, if that sponge is capable of forming or allowing bone formation, if I have this folded in half, I would basically try to address the problem from both angles, from the bone side as well from the soft tissue side. So that's the rationale for this type of absorbable scaffold for treatment of buccal concavity defects. That being said, my first experience with this were related to immediate implant placement. So here I have placed an implant, have ideal primary stability. I have a gap between the implant and the socket walls, which I'm filling with a particulate material, in this case here, a cancellous-based allograft. But I'm still worried about the contour and the potential changes that will happen on that buccal plate. So instead of only using graft material, I'm using the graft material inside the residual socket, and I'm covering with this scaffold on the buccal aspect of the ridge, so buccal to where the bone was. Closing the area up and letting this heal, and being very impressed with this over time, because this is a 4-month follow-up on this case. And I can see that the contours have been properly maintained. Color match here is very ideal. And if you look at your picture on the right, you can almost see that that scaffold is still present. And you can almost visualize where that is with flash photography, something that you wouldn't be able to see normally if this patient was walking down the street. But with flash photography, we can see that the material has been stable for all this time. So very different to the other collagen materials that we have tested and used in the past. So with this, I've decided to then apply this to the development of this buccal concavity defects at second stage surgery. Why at second stage surgery? Because I believe that at second stage surgery, we have all the tools that we need to achieve proper soft tissue development, because we don't have to worry about an implant integration anymore. That implant has been completely integrated at this point. You tested at the time of second stage surgery. And now we can focus on that soft tissue development, on that static development of the area. So as you can see here, we have an implant that's completely covered by bone, but a thin layer of bone. And we also have this concavity that is formed by the presence of 2 adjacent teeth, which have much more buccal lingual dimension than that implant body has. So instead of putting a bone graft material or putting on a tissue graft, all that I did here was simply folded that scaffold in the middle, so double layer it, and intentionally place it away from the defect or away from bone, sort of like to create a retaining wall facial to that implant. What is the idea behind this? The idea is to still have a viable blood clot in between bone and this dual scaffold, and having this inner layers of the scaffold help this blood clot that formed there to potentially ossify, while we have the outer layers of the scaffold helping with soft tissue development. Because since this is a multi-layer construct, these layers will eventually start to separate and create an effect of tissue expansion over time. How long does this take to happen? Well, on a situation like this where we have a defect that has low regenerative potential, as we all know, this is a one-wall type of defect. This is a process that may take anywhere between 9 to 12 months to fully complete. But what we see on the right is the immediate effect of the volume that is being achieved by the placement of this material. This volume is then altered and changed with the use of provisionals, creating a much more aesthetic soft tissue contour for better emergence profile of the restoration that will be placed there. So this is very similar to what we would have done with either a bone graft or with a tissue graft that we had placed in that area. So what's very interesting is to then look at this site over time. Not only we have seen stability of the static case that we created by the use of this absorbable scaffold for this purpose, but what is also very interesting is to look at this over time on a CT scan to see what's really happening, because it's interesting enough to have stability of the ridge contours for aesthetics, but it's even more interesting to look at the CT scan and identify now a much thicker buccal plate than we had when this material was placed. So this to me was a big eye opener and has really changed the way I look at this type of defect. So this became a protocol. This became my go-to material for this type of situation. Placement of this dual layer or this dual scaffold as a double layer at the time of second stage surgery. And with that, we have also follow-up. I have also follow-up some of these cases for up to 3 years. And specifically this case that I'm presenting here, I can show you what this looks like 3 years later. This is, to me, it's a huge game changer in the management of this type of buccal deficiency, buccal contour deficiency that we have seen in implant dentistry. Because at 3 years, not only we see that stability of that, but we see additional mineralization and creation of a much more natural contour for that ridge. You can see the additional ossification that happened within this construct that has maintained this stable over time. So this is very interesting, very fascinating, and something that I believe that completely changed the way we look at this type of aesthetic challenges that we have in implant dentistry. And as I said, this has become the norm for this type of situation, either at the time of implant placement or at second stage surgery. The great advantages of this is not only the high aesthetic result, but also the stability of the case over time. How much of this scaffold will actually become bone? I think it varies a lot from case to case, depending on the nature of the defect. The deeper the concavity, probably the greater the chance for mineralization. But mineralization here is not the main goal. The main goal is to address the aesthetic problem and create a much more ideal site for an aesthetic implant restoration. So it's almost like if you have mineralization, great, that will give more stability to the site long-term. But the main goal, which is to create an aesthetic case, can be easily accomplished with the single use of this type of dual absorbable scaffold without the use of an additional grafting materials or anything like that. So this is what I'd like to share with you today. Thank you.